Good morning, everyone. We're just going to give everybody a moment or two to log on, and we'll begin shortly. Okay, good morning, everyone. Thank you so much for joining us for Virtual Insights on Kidney Transplant. Our topic today is exploring paired kidney and expanding donor options. Our speakers are Judith Hambledon, Chief Transplant Coordinator, and Eliza Bensley, Clinical Transplant Educator. We encourage you to submit your questions in the Q&A section. Today's session will be recorded and sent to all those who registered. It is my pleasure to turn things over to Judith and Eliza.
Good morning. Judith Hambleton, Chief Transplant Coordinator here at Cornell. Today our topic is living donation and all the different options that people now have. So jump right in. The very first successful kidney donor transplant was performed in 1954. This was done at Brigham in Boston, and it was two identical twins that you can see over there on the right. Living donation takes place when a living person donates a kidney for transplant to another person. And just as a reminder, healthy people can live a long, long life with just one kidney. In fact, it's on a rare occasion when we're screening our donors, we sometimes see people with one kidney or three kidneys, or it's not usual, but it's certainly not unheard of. Next slide. So let's look at a few facts. Kidney transplant is certainly the preferred option for most patients with end-stage renal disease. Obviously, if there are so many comorbidities, it may not be the best option for a select few. But a living donor transplant is certainly superior to a deceased donor transplant. And on average, we expect a living donor transplant to last about twice as long as that from a deceased donor. That said, statistically, we know that at 1/3 or 33% of the pairs that are going to present for living donation are not compatible. And we're going to talk about what that means shortly. The goal of paired exchange is to increase the number of organs available, and we're certainly going to investigate what all this is about. So donor exchange can be used to increase donor-recipient match and reduce the requirement for immunosuppression. So these are the things to keep in mind as we go through the slides. Donor swaps also increase convenience for the donor. Next slide. So let's have a little game first off. Fact to fiction. Your donor needs to be the same donor at the same blood type. True or false? So false. A donor blood group can be compatible without being the same. And obviously, in that situation, the donor can donate directly to the recipient. However, blood groups can also be incompatible. And for that, we now have donor exchange, which we feel is really the best option. So is there an age cutoff for a living kidney donor?
And you guys can answer in the chat box. Sorry to jump in, but before I show the answer.
Okay.
Anyone?
It's kind of a trick question.
All right.
So false. We've had living donors that have donated up into their mid-80s now. This is not the norm. I would say it's certainly the exception, but there are some 80-year-olds that are extremely good health and have actually gone through the process and done just fine. Now, on the other end, while the federal law mandates that 18-year-olds can donate, here at Cornell, we don't feel that we are a lot happier if someone is 21 or older. Really, at 18, is someone mature enough to make these types of decisions. Can you still have children after donating a kidney? Anybody want to take a guess?
We have a hand raised. If you can go to the chat box and type your answer. I think we're gonna get a guess.
It would be in the Q&A section that they can put the comments.
Yeah, that's a good.
So not the chat at the bottom.
There we go.
Yes, yes, we got an answer. Yes. Okay, let's show the answer. Great participation.
It's true. You can still have children, obviously for females after donating a kidney. But what we do recommend when a younger woman comes through, we do, if this is something that she's thinking of doing, she should really discuss it with an obstetrician. If she's had past kidneys, has there been an increase in blood pressure, those types of things. So that's certainly up for discussion. And that's what our recommendation would be. Okay, next slide. So once again, once you donate a kidney, you're left with only half of your kidney function. True or false? Okay, let's.
Any
Eliza.
takers? All right.
So false. What happens? Your remaining kidney does compensate as the months pass following donation, and typically at about 6 months, you have about 75% of the initial function. In other words, your own kidney that's left behind somehow recognizes that its mate is no longer, available, and therefore it gets bigger and takes up again. Could be 3/4 of the function. Living donors need to be in good health. I think that's a pretty easy one. I threw an easy one in there. You wanna?
We got it. Yes. Good.
Yeah. So certain health conditions such as diabetes, certainly it's the most common that we see. But that could certainly rule a candidate out. But all candidates, when they first apply to be a living donor, they complete a health questionnaire. It's about 4 or 5 pages. If anyone's ever seen anyone complete this, it's pretty intense. And also we delve into family history as well. So, we don't want to waste people's times, but again, we don't want to rule people out unnecessarily either. So your donor needs to have a biological or emotional relationship with you. True or false?
I should have put the Jeopardy music on. Any takers? Any guesses? All right, time. Oh, false. We got a false. Thank you for participating.
Yeah.
Okay.
So it's true. It is false. We commonly use altruistic donors now who've never met, never heard the name of, will never know where their kidney is gone. It's not so long ago, I'd say 15 years ago, there was only one organization in this area that would accept altruistic donors. So we've certainly moved a long way in just a very short period of time. However, having said that, it is illegal to pay organ donors, but you can assist with their donation expenses. So this is something that needs to be very clear. You cannot say $10,000 to give me your kidney, but you can, supply $10,000 if that's what it is, for airfare, hotel, and bringing a caregiver, those types of things. So it's important to know the difference between the two. Okay, let's move on. So, I always plug the program just a little bit. We're certainly one of the highest volume transplant centers in New York. Last year, we did a total of 286 transplants, which was actually our year's, it was the maximum we've ever done. We are the largest living donor transplant center in New York. We are a Medicare approved center. We were the founding member for the National Kidney Registry, for any of you that have heard of the National Kidney Registry, and we are ranked amongst the top national kidney paired exchange programs. Our mission is and always has been to maximize opportunities for transplant, and we do this by increasing access, improving our outcomes and safely transplanting our patients. Next slide. So go Cornell. So importance of early referral for transplant. This isn't something that I can stress enough. Getting an evaluation early, it just gives people a lot of insight into what they're facing and the best way that they're going to handle this. And by doing so, you improve your chances for long-term, longevity. So if you're not yet on dialysis, but your GFR, I'm hoping most people know what that means, but it stands for glomerular filtration rate. It's a measurement of how quickly your kidneys can actually get rid of the poison in your bloodstream. If you have reached 20, that means you are eligible to accrue waiting time on the national transplant list. So an early referral, get here, be ready. So as soon as your creatinine level, i.e. your GFR, allows it, we can flip the switch and you will now be active on the waiting list. Now, if you began dialysis before you were listed for transplant, and this can happen, you may be completely unaware that your kidneys were failing and, I've been feeling fine. And then just suddenly, you hospitalized and your kidneys fail. Then this will be calculated then from the first dialysis date. And Medicare keep track of all this data. So we will be able to backtrack that and get that for you. But your doctor's going to be doing you a great favor. I like to talk to people personally when their GFR is around 25 to 30. They can start to think about donors. They can start to think about, is that going to be right for them? It just gives you plenty of time to plan things out. Next slide. So we're flipping over back to the donor side. So the evaluation process, and I realize that most of you that are on here are recipients, but the reason we're giving you this is so that you can talk to, if somebody approaches you about potentially being a donor, then you're comfortable talking to them. You know a little bit about the process, how it all works. So if you've got any living donors, have them register. It's cornell.donorscreen.org, and that leads them to the 4 or 5 page questionnaire that I was talking about. Please don't rule your own donors out. Let the trained living donor team make the determination of who can come for a cross-match and who is ruled out. All donors undergo a thorough evaluation, and we assess their medical and emotional suitability to be a donor. I should also add on there their financial ability. If it's a huge hardship to a donor financially and there's nothing that we can help them with, then that could potentially, be a stepping obstacle. So the evaluation is done to protect the potential donor, and we want to ensure that if people are at risk for things such as hypertension, diabetes, morbid obesity, either now or in the future, then we're protecting those people by not letting them move forward. Donors do not have, if they feel coerced, then that is not a healthy time for someone to donate. And this doesn't have to be in a malicious sense. It could just be that maybe they're the only person in a family where everyone is obese and have hypertension and diabetes. They may be the one that eats, a very healthy diet and exercises every day, and they're the only suitable donor in the whole family. And that can even in itself look to be coercive if that person doesn't feel like donating. So donators cannot put themselves at socioeconomic risk, and we sort of broached on that a couple of questions ago. Next slide. So benefits of living donation. Well, let's talk. What are the benefits for the donor? You always assume this is all something that the recipient sees the good in. Well, that's not necessarily the case. So for donors, they frequently have an improved quality of life score after donation. They feel that they've done the right thing. They feel good physically as well as mentally, and those scores can improve. It's a minimally invasive procedure. It's literally a single port donor nephrectomy that we use here. The incision is basically through the belly button, and it's almost invisible to the eye after just several months. Studies have also shown an increase in self-esteem and well-being. Donor evaluations have led to early detection of medical issues that we wouldn't normally pick up. I remember off the top of my head 2 instances of, it was 2 men and they were both in their early 40s. We picked up pancreas cancer and they were both fine. It was very early, but it was picked up and they were able to treat them. Obviously, you know, they weren't able to donate, but and that's just 2 instances from the top of my head. Next slide. More benefits. This is for the recipient. Well, you're not going to have waiting time. If you are already on dialysis, you know, it's those of you that have experienced it, it's not easy, and there's certainly an adjustment period. But to be able to go from your evaluation straight to transplant and miss dialysis altogether, that would be optimal. We do schedule surgery to optimize the recipient's health, meaning that, you know, we don't want to do a transplant too soon. If someone's GFR is at 20 and they're having absolutely no symptoms, then that's not the optimal time to transplant this person. We would wait until probably mid to, you know, anywhere between sort of, I'd say 12 to 15 would be the optimal time. And of course, the time has to be good for the donor first and foremost. So surely the surgery, we would like it to preempt the need for dialysis if at all possible. Living donor kidneys statistically do have double the lifespan of that of a deceased donor. Living donor kidneys function while the recipient is still on the operating table. That's something was one of the first things when I came into transplant. I went to see a living donor transplant surgery and couldn't believe it. The kidney barely knows it's sort of changed sides. And most recently, there is opportunity in something called Kidney for Life. This is where we're looking at eplet matching, which we'll talk about a little bit later. And this is really the future of transplant and where we're going. And currently, that's only available if you have a living donor. So, next slide. So the principles of living donation. Basically, the person who gives consent to be a live donor should be competent, willing to donate, free from any type of coercion, medically and psychosocially suitable, also be fully informed of the risks and benefits of being a donor, and fully informed about the risks and benefits of alternate treatments that are available to the recipient. Next slide. Compatibility. All right, now this is a little bit of brain work to do. So the first thing that we talk about when we're talking compatibility is your blood type. So you can see on this chart here that a person with blood type A can receive a kidney from someone with blood type A or O. A person with blood type B can receive a kidney from a donor with blood group B or O. An AB recipient can get a kidney from an A, B, an AB, or an O donor. So in other words, is the universal recipient. You can get a kidney from anyone. And then we've got O, can only get a kidney from blood group O. So AB is the universal recipient. That's great news if you're an AB and you're looking to get a kidney. It's a little bit easier to find a donor. Unfortunately, blood group O is able to donate to everyone, but is only able to get a kidney back from their own blood type. So that's a little bit of a hardship for us, those of us that are blood group O. And just so that you're aware, 50% of people in North America are blood group O. So the next thing we look at is genetic match, and then finally there's something called a cross match. So let's go forward and have a look at those. Next slide. So HLA, again, this is not, you don't have to memorize this, understand it, or anything else. It's just put in as a little bit of interest for those, that like to understand what we are doing behind the scenes. So HLA, or human leukocyte antigens, each person has these markers in their blood cells. It's carried in the white blood cells. In kidney transplant, there are 6 of these numbers, these unique markers that we're looking at. And these numbers are called antigen. And this is what we use to determine the degree of the match. So although matching can be important, for example, the 6 of 6, which we'll talk about in a minute, it's not critical to the success of transplant. And if you have a healthy, willing donor and they match 0 of 6, that does not mean that that transplant could not move forward. It certainly, we certainly can move forward. So HLA identifies us as self. So when we take any foreign substance, it could be a kidney transplant, it could be blood transfusion, it could be transplant, blood transfusion, or pregnancy, then your body recognizes that as non-self. And you think, well, with pregnancy, how does that happen? Well, the baby that mom carries is still half the father. And so the mom's blood recognizes the father's part in that baby as non-self. And we do actually see a reaction between, when we have a mom that needs a transplant and the father of her children comes to donate, she could see him as foreign, just for the simple reason that she carried his child. So those are the three things that can expose you, and you create these antibodies. The antibodies then identify if you ever see that material again, i.e. pregnant woman, the father of the donor offering to donate. It's not always the case, but quite often we will see antibodies against the dad. Next slide. So shared antigens. So each of us have those 6 antigens that we were talking about that we look for when we're talking about transplant. So when you have you test a parent and a child, they are going to be 50% of the HLA. In other words, they're going to match 3 of those 6 numbers. The other parent will have the other 3. So you inherit everything by halves from each parent. Now, if you have siblings being checked with each other, they can share anywhere between 0 to 100%, or 0 and 6 of the HLA matches. Identical twins is taking this a step further, and they are DNA identical. So in all honesty, when we get identical twins, it's rare that this happens, but it has on a couple of occasions, that we're actually able to transplant the donor into the recipient, and we don't even need to need the immunosuppressive medications following, because it's identical. It's like their own kidney, identical to their own kidney. So the tissue typing match can certainly impact this lifespan of the transplanted kidney, but bottom line is 6 out of 6 were cheering at the tops of the roof. That's a great match. And historically, we're looking at a deceased donor kidney lasting 10 years, a living donor kidney lasting about 16 to 18, and for a 6-match living donor, we're looking at that match lasting around 28 years. So you can see the 6 of 6 is significant. However, the difference between 0 and 5 is quite minimal. It's negligible. So if you have 2 donors and one is a 3-match and one is a 2-match, it's not going to make that much difference. Just be grateful that you have someone that is a match. So again, that identical match organ may last a lifetime without any types of immunosuppression, but it's a rarity that we get to see that. Next slide. So the crossmatch, you'll hear that term crossmatch quite frequently. And what this is, we're taking blood from the recipient and the donor, and we're mixing it together. We put it on a plate and basically watch what happens. And essentially what we're looking for is, does the recipient blood attack the donor blood? If so, that means there are antibodies, and the antibodies are destroying the donor blood. And if we were to use that person as a donor, then that's when we would see rejection. So this is a cross-match is basically looking to anticipate rejection between a donor and a recipient. Now, again, these antibodies, they develop because of the transfusions, transplants, and pregnancies. So what are we looking for when we're looking for a donor? So in a, again, ideal situation, a living donor, young, healthy, they're ABO incompatible, we have a negative cross-match, there are no antibodies against that donor. Having said all that, you know, it's not, as we say, a third of people that present, this isn't a possibility, this isn't something we see. So for a third of those people, we've now come up and learned how to deal with it. So there are things that we can potentially do for these situations where a kidney is not compatible, and we'll take a look at them. Next slide. So incompatible donors, what's the first thing? So historically speaking, if you had a blood type that was not a match, or you had antibodies against your donor, so that would be an ABO incompatible or a positive cross-match, we were able to desensitize. And what that means is basically try to get rid of those antibodies that is causing the problem between these the donor and the recipient. So we used medications, and we used treatment that's very similar to dialysis. It's called plasmapheresis, and we were able to try and lower the level of antibodies. Now, what's the disadvantage of doing these desensitizations? Well, the recipient's getting more medication than they would if the donor were compatible. There's always going to be a higher risk of rejection in these types of transplants. And despite this type of treatment, we're not always able to actually rid the recipient of these antibodies. And if that's the case, we still have the antibodies and the positive cross-match, and so we're not able to move forward. So that's option one. Next slide. Option two is donor exchange. And how this works, at Cornell, we work exclusively with the National Kidney Registry. You know, we feel that they are certainly the largest in the country, and very efficient, and we've always had a good experience with them. Per the facts, we were the founding center, and we did the first four-way, so 4 pairs, all exchanging. That was 8 surgeries that occurred February 14, 2008. As far as the NKR go, they've facilitated more than 9,000 living donor transplants since their existence in 2008. And this year, in 2024, they've accounted for 25% of all living donor transplants in the US. They really are quite a huge organization and work with, I would say, you know, the biggest, most experienced of the transplant centers around the country. And because of this, they have a large donor pool, and this allows you to find a donor that is better matched and almost an improvement on the donor that you have. And what we've started to do in the last year or so is give the option for people to enter this Kidney for Life. And what Kidney for Life means is they're looking for a very, very well-matched kidney. So, you know, before we've talked about the 6 out of 6. Well, that's the very sort of surface level that's available. And we're going to talk more about the, you know, the more distinctive typing later on. As well as entering for Kidney for Life, the donors also have specific donor protections that the National Kidney Registry, because their organization is so big, they're able to give specific donor protections, and Eliza's going to talk a little bit about that in just a few slides. Next slide. So with the exchange, it started off very, very basically as a paired exchange. So you can see on the right-hand side, you've got pair 1, mother and son, and pair 2, wife and husband. Well, in this instance, mom wanted to give to son, but she was not compatible. So she donated to paired 2 wife, and then the husband who wanted to donate to his wife and wasn't able to donate it to the son. So this was the very basics. We were even able to accommodate some of these transplants before National Kidney Registry came into existence. But when they did come into existence, it just allowed us a bigger play and a bigger donor pool. So the disadvantages of this type of exchange was that the recipient and donor undergo surgery, all of it's done on the same day. And if, let's say, you're the father of the mother-son team or a child of the husband and wife, then that's a lot of stress. You've got both of your parents in the operating room pretty much the same time, or your wife and your son in the operating room. That's a lot. It took longer to be able to find suitable donors. And so while this worked, and we certainly used this for a few years, we were able to sort of progress. So next option. So the donor exchange and the benefits that are offered through donor exchange and working with a group like the National Kidney Registry. There are a lot of things that they're able to do, again, because of the vast number of donors, than we're able to do as a unit unto ourselves. So the donor is able to donate at your convenience. If you're an advanced donor, let's say it's a daughter who desperately wants to donate to her father. He's not quite ready to go to transplant yet, but her winter vacation is coming up and she's going to have 3 weeks off school, and that's when she'd like to donate. She can donate then, and then if the recipient, as soon as the recipient is ready, we activate the recipient and they're able to move forward. So advantages for all this, well, it's a shorter waiting time for the recipient versus a paired exchange. It opens the flow up and it doesn't lock us down to having to have a donor and recipient both ready at the same time. The donor is matched, and then in the future, the recipient is matched. Avoids the 2 family members being in the operating room at the same time, or at least a day. It's less stressful. A thing that became very evident, very often it will be a spouse donating to either their husband or wife when we're talking about these exchanges. And what it allows is for the donor to actually donate, recuperate, and then be available to be the primary caregiver for the recipient. And that's huge for an elderly couple that maybe, their kids don't live in the area. That can be a big benefit. You can also get better matched kidneys. Again, that just minimizes the risk of rejection and could potentially lower the amount of immunosuppressive medication that you would need. The degree of match, that's age, other donor characteristics, can be predetermined by the recipient and their team. In other words, it's like going grocery shopping. I want a kidney between the ages of this, and I want this degree of match, etc., etc. The donors, but we brought this up again, the donor shield. We're going to be talking about that in a few slides. And there's also room for remote donation. So if you have a sibling that's out of state and they don't want to travel to New York, then they can actually be evaluated and donate out of state, and the kidney be shipped to you if it's a direct donation. If it's an advanced donation, they donate whenever they want, and then we get a kidney out of the pool for you down the road. I hope that all makes sense. Next slide. So anybody got questions about that? It's a lot of information, I know, and we've got a lot more to go through. So I certainly hope it's clear to everyone.
Yes, I mean, it's definitely a lot of information. If you guys feel a little overwhelmed, this is all being recorded. We'll be able to have you access this. Or if you have specific questions about anything that we mentioned, Judith or I would be happy to have a conversation offline about the specifics. But I will continue on with, type them in. Judith did an incredible job talking about the National Kidney Registry, and obviously mentioned we're the founding center. So NKR, again, you always hear us say NKR, that's just their abbreviation. There's an easy online screening tool. We can do local testing and workup. So if you have a donor who is interested in donating in their home state, maybe traveling is restrictive for them, we can find a local NKR center and they can do their workup with them. We also have options for remote blood work. We really do want to work with the donor to make it as accessible and as easy as possible. So there's a lot of options. And if you feel like there might be a barrier, talk to our team and I guarantee you we can figure something out. We're pretty flexible. And so, as Judith mentioned, there's advanced donation, there's remote donation, there's family voucher. I'll talk about the voucher program in the next couple slides. And then we have the Microsite program, which many of you have heard about, with the website findakidney.org, and Donor Shield, which I'm actually going to show a really nice video that will talk about the donor protections. Additionally, I love that there's the donor mentor involved. So every person that registers to become a donor can opt to speak to a donor mentor, which is someone who has been a donor before. And I think that really is a useful tool when, honestly, as a team member, if we haven't been through the process, it's really nice to talk to a patient. And then the home blood draws and the donor shield protections, which, again, we're going to go over. So just to go back a little bit, remote donation, the donor can be evaluated and undergo surgery at a remote center. We have relationships with centers cross country and even have, experience working up international donors. And it's nice because there's no need for expense and inconvenience of travel, and the donor's kidney is shipped to us if donated directly. I will say a lot of patients choose to come to Cornell. They do make that flight and they do want to get worked up at our center, but there are incredible transplant programs across the country that we can work with if they're an NKR center. And then Judith really did speak about this, but the advanced donation is the convenience of having the different times with the recipient and donor undergoing surgery, and therefore there's that caregiver element. And also, we've seen a lot of advanced donation happening with grandparents wanting to donate their kidney to a grandchild. And so if their grandchild should ever need a kidney in the future, they're donating in advance, as it says here. So the voucher program, I think the voucher program is one of the neatest things that the NKR offers. There are two types of vouchers, standard and family. And to learn more, we can talk about that offline. But basically, the voucher allows for the living kidney donor to choose the most convenient time frame for their kidney donation surgery, essentially putting their kidney in a bank. Living kidney donors can provide a voucher to a selected person who can then be prioritized to receive a living donor kidney transplant. So this is a great story, as you can see below. You probably, if you attended our sessions, you recognize these people. But Sophia Jackson was a donor we had on our webinar 2 months ago. And she is an incredible story. She was watching the news, walking through the airport. She's a New York native, but lives in Utah. And she saw a news channel broadcast about Vadrian Alston, mother of 2, who needed a kidney transplant. She was so moved by this story, she decided to come to Cornell and get worked up to be a donor. And during that process, she found she was incompatible. And at first, she was really devastated because she emotionally wanted to help Vadrian. And learning that she could donate through the voucher program really opened up many doors. She was able to donate her kidney on Vadrian Alston's behalf. Her kidney went to another patient. So she not only helped Vadrian, she helped another patient. And then Vadrian was activated in the system and able to cash in that voucher and found a compatible donor. And it basically changed her outlook and how much time she would wait for a kidney. And then the two of them really very happily met. And it's just been really amazing. And Sophia's been a huge advocate, and so has Vadrian. So just a real life story to see it in action is really cool. So Donor Shield, this is the video I want to share. I hope everyone can hear. And we have no issues because sometimes technology likes to sneak up on me.
When you donate a kidney through the National Kidney Registry, all your donation-related medical costs are covered. But you may have other non-medical expenses related to the donation. You might lose wages because you have to take time off work. And you may have to pay out of pocket for travel costs, dependent care expenses, and more. Donor Shield helps with those expenses, so your kidney donation is not a financial burden on you. If you donate through the National Kidney Registry, you are automatically covered by Donor Shield. Donor Shield will reimburse you for up to $12,000 in lost wages and up to $6,000 in expenses for travel, lodging, meals, and care for children or adult dependents. In addition to cost reimbursement, Donor Shield offers a wide range of support and protections. Donor Shield offers kidney prioritization in the unlikely event you ever need a living donor kidney transplant in the future. Although complications are rare, Donor Shield will also reimburse you for any uncovered costs you incur related to complications from donor surgery. Visit kidneyregistry.com to learn more.
So there's obviously a lot more that Donor Shield does that they don't cover in that video, but and you should go to the website. Again, as Judith mentioned, many of you on this webinar are recipients, but the more you know, it really can unlock the conversation that you're having with potential donors, give you the confidence to talk about it and to dispel any myths that maybe patients or potential donors have. Talk to family members about this, talk to family members about the opportunities, and just make sure you keep speaking about the fact that you're looking for a living donor. That's my biggest advice. And having Donor Shield is really incredible for potential donors. I'm thrilled that anyone who goes through our NKR system is qualified for that protection. So just wanted to cover that. And now we are jumping back to the information Judith was talking about, which is the HLA, tissue typing, and Crossmatch. But throughout our history, there have been incredible changes in tissue typing technology. There have been huge gains in reducing early graft loss, but later graft loss remains the same. So this is just an example of the low resolution antigen level, and the example is seen at A02, and then the second is the intermediate resolution, includes a subset of alleles, example A0201, and then high resolution set of alleles that specifies and encodes the same protein sequence, and the example is A0210100202. Did you lose me there? So as you can see, it's just so much more advanced, and we can get to from low to high, and it's very important when we're analyzing the tissue typing results. And so we also, when we look, we are looking at class 1 and class 2 alleles. And so this is really something when we're looking at matching and working with our immunogenetic specialists, we're looking at these levels. So the next slide is just the third generation of tissue typing, and it might be a little hard for you to see, but you can see just how in depth and specific it goes. And it really ties into the next level and the next generation of tissue typing specificity and sophistication, and that's Kidney for Life. So our program is now participating in the Kidney for Life initiative, which is through the National Kidney Registry, and it utilizes the latest technology in DNA sequencing, and it's looking beyond just that HLA marker. It's looking at epaulets, and those purple globs up there are the eplets. And so they're the smaller components of HLA. And so when we look at this, it allows us for improved matching. The better the applet match, the lower the chance of rejection. So the large donor pool that the National Kidney Registry allows us, we can look at these applet matches and we can help patients get a low applet mismatch. And when we say low applet mismatch, meaning a better applet match, it can be kind of confusing when we say low applet, but the better the match, it allows the transplanted kidney to last as long as possible with a potentially less immunosuppression, which is meaning less side effects. And so again, when we talk about patients entering the paired exchange, we may have someone come to us who has a compatible pair, someone who they could go forward with transplant, but maybe they want to try and get a better match. Maybe they want a low applet mismatch. So they can enter this program and we can look at an even more specific type of DNA sequencing, which is really incredible. This is relatively new. I mean, it's new in that we're participating in it, but the data has been collected for a while. So another bit on Kidney for Life. So again, Kidney for Life, precision capability, compatibility for lasting kidney health, lower risk of rejection, less risk of graft kidney failure, lower dose of transplanted medications with diminished side effects. And all KFL donors have access to Donor Shield. And we're actually one of only 10 programs nationwide offering our patients this system. And so I encourage you to learn more and ask your coordinator about Kidney for Life. We are definitely encouraging all of our patients to consider a low applet mismatch just because it means that their kidneys may last longer. So talking about the logistics, applet testing does need to be obtained early in the transplant process. All living donor pairs could benefit, and it's just really important for everyone to have all that information. We don't advise it for two haplotype matched siblings just because they have such a, that's already a great match. But compatible pairs, as I mentioned, are prioritized in the NKR. Timing and knowledge is key. Recipient and donors both must understand the potential benefit. And, this may be less essential for older recipients, but it's definitely a really unique and special opportunity. So we're very excited about it. Next, the Microsite program. So our team can help you create a free personalized website to help you find a living kidney donor. Once approved, you'll be able to spread the word, and you just never know who could be touched by your story. Your site gets activated and you'll get 250 free business cards to share. And the microsite can be shared on social media with friends and family. And if you're interested in learning more or you want to create a microsite, we can do that. This is a great site. I just wanted to show you an example. As you see, the person's name is clearly listed at the top. There's a photo. They have a section to write who they are, why they need a kidney, and you can help share their story with links on top. And then there's a button to see if you're qualified to donate. I also love that the microsite also has the donor support and protections that we kind of just spoke about available to anyone on the site. So it links them to the Donor Shield website, and again, guides them to start the donor screening process. And there's more opportunities for customization. So again, my philosophy is every recipient who doesn't have a living donor should have a microsite, because the alternative is you don't do anything and then you really don't know if you can find a living donor. But just getting it out there, it makes it easier for people to talk about the fact that they have kidney disease, they need a living donor. It's just this free tool. So we really encourage people to participate. And then, of course, we have to highlight our 60th year. We just celebrated our 6,000 transplant and our 60th anniversary. So we've been busy, which is great. And 2023 was a great year for us. We were #1 in New York for living donor kidney transplants. And it was our highest volume year in our history, which is really incredible. We did 286 kidney transplants. So we have been busy, and we're just going to keep going and continue to transplant folks. So hopefully you've seen our website. It's weillcornelltransplant.org. All of the resources we talked about today are on the website. There's a whole entire section to kidney paired donation if you want to learn more. And then about living kidney donation, our education center, our adult kidney transplant center has all of our events and the webinar recordings. So please visit our website if you'd like to learn more. And while you're there, this is our upcoming schedule. So June, we are going to be talking about transplant medications post-transplant. And then in July, post-transplant care. Then in August, nutrition for transplant recipients pre and post. And then September, we're going into the fall. We're going to talk about mental health and well-being. And then October, we're going to talk about pediatric transplant. And so we have a really exciting agenda ahead of us. We're also doing this presentation tomorrow for anyone who just is eager to hear it again. And then more resources again on our website. I encourage every person in attendance to watch the Big Ask Big Give. It is on our website under comprehensive resources, microsite page, and I can send it to you if you can't find it. And then our next slide is about our transplant support group. This is a support group offered by Trio, and they do have in-person locations. And as you can see, Manhattan, Orange County, Rockland County, Staten Island, Westchester, the Bronx, and Putnam. Here are some resources if you'd like to join. I think, again, just much like the microsite, all recipients should consider a support group. I think it's a really valuable tool, and you can learn so much through the experience of others. We also have a support group, and we meet on the second Wednesday of each month. We will be meeting, this date is from May. We'll be meeting on the 12th of June. And we have really found it valuable, and our patients have as well. So, oops, sorry, this is a little bit of a dupe. Connect with us on social media. If you are not following us on our Facebook, Instagram, or YouTube, please do that. You can scan this QR code. And then I also just wanted to pitch our newsletter. We send out a quarterly newsletter, and I'm always looking for patient stories and anyone who wants to be featured. So if you're interested, let me know. I'd be happy to do that. And you can send me an email at elb9128@nyp.org. And then lastly, just additional resources. This is our contact information, Judith and Eliza, the National Kidney Registry website, Transplant multi-listing website, and then the SRTR website, which has all the data and reports of the local centers, and then OPTN and organ donor transplant, and of course UNOS, which is where you're listed nationally. So there you go. Questions? And I realize we are 3 minutes to noon.
I
So
was just going to say, good timing there, Eliza. We've either confused everybody.
yes, I mean, it's
it
a
was a good
lot.
presentation. Yeah,
It's a
it was
lot. And if it feels overwhelming to you all, just remember we've all been doing this for years and years and years. And, it's still, because of the changes in the innovation, it's still a lot to understand and process. And I want to thank everyone for taking time to join us. Oh, we've got a question. Oh, very informative presentation. Thank you. Thank you for participating. All righty, guys.
All right, everyone. Thank you so much for joining us. Eliza and Judith, thank you so much. I know that this was a lot of information, but I think it was extremely helpful. And again, if anyone thinks of questions after, please feel free to reach out and we'll do our best to get back to you as quickly as possible. Thank you all for being here today, and we'll be sure to send out the recording. Have a great
Thank
day,
you.
everyone.
Thanks,
Bye,
everybody.
guys.
Bye-bye.